Good morning. Thank you really, Mark, for the invitation and to organize this session, because that's really a work in progress. So it's a project that is almost done. It's not done yet. And I will show you all the street that we had together with the international working group. So we decided to give you an up-to-date about this project, because how we heard yesterday and Monday, the post-operative classification that we need to start to call in this way is something that we need to understand what's going on after surgery. So that was the main aim of the project. I'm really happy to have the co-chair Edoardo. Rena says sorry, but is the co-chair of the project. She needs to leave. She had a long trip, so she really says sorry. She wanted to be here. It was impossible. So we asked Edoardo, is one of the chair of the subgroup that now you will see, to be here with me. Thank you.
Morning also from my side. Indeed, I'm taking the place of Rena. Rena is much more better than me, but apologize for that. And I think that we can start immediately. So Renato will give a short presentation just to introduce the topic and the classification. As he said, this probably, the work is almost done because the statement were already voted, and they prefer to present all this classification at a later stage, probably next year, the DDW, and but we will introduce the statement and so on. So there is room to improve. So if you have any comments, please do them.
The setup of the PowerPoint has changed. We've not got the... Hang on, resume slideshow. The slides are there, but it's...
But it's not there.
It's not... There's something wrong with the slideshow function. It's very odd. Forgive me, everyone. I'll take that sound as a good one.
Yeah, probably now it's...
Yeah.
Perfect.
Okay, so that's what we say. We need a consensus to understand what's going on after surgery. That was the main aim of this working group. So when we are talking about the Chicago 4.0, we decided, okay, we need to understand something about after surgery, what's going on after surgery. So how you know, in Padua, we are a really big surgical center, and so we decided to try together, have an international group, and try to figure out what's going on before and after surgery. So we decided to make an airplane together. So me and Rena were the two co-chair. We asked 4 young reviewers to do all the review about these topics that now you will see in literature. And we decided to divide the group in 5 subgroups to see what's going on for candidacy for anti-reflux procedure, to see if you have any high-resolution manometry help to understand the pre-operative anti-reflux patient. The main topic was absolutely the post-operative classification. How we heard yesterday, you need, many of you had a comment about post-operative surgery, and so we decided to make together all the data and to see if we can have a post-operative classification. And after, we decided to move to the bariatric. Bariatric is a really strong topic in this moment, especially we talk about GERD and bariatric surgery with all the different procedures that we had. So we decided to make the same design for the bariatric surgery, pre-operative and post-operative patient. So we make together all the chair, and we gave them the rule to understand the main topic inside of every single subgroup. That was the aim and the mission of all the group. In the end, we decided to take the candidacy a little bit outside from the from the first version of the Padua classification, because with the candidacy, and we will hear from Mario the presentation, we can have also other procedures that need to be done before going operating room. So the group was just for high resolution manometry, so we take a little bit far from the classification, the candidacy group, but of course they are still involved and they will show us what they did. And that was the street. The project started 2 years ago. We make together the international working group, of course was a pandemia time, so we had the meeting by Zoom, like the Chicago 4. Initially, we tried to make together and understand the question to the PICO format. After the 4 young reviewer performed the literature, just about, we asked before just about high resolution manometry because it was the group, but we included to understand, to vote also some conventional study that was already done with the conventional manometry. We had the first round with the RAM method. After we review all the results and we modify some statement, that was the method that we decided. We had the second round for the vote, and in the end we produced the final statement. You will see today not the final vote because that's not the announcement of the classification. You will see all the statement that we vote with all the group, with all the international working group. The manuscript, I mean, is almost done. We just need a couple things in the discussion that also we wanted to wait this meeting to see the opinion of really international experts, and probably the announcement. The classification is done, I mean, and the announcement, how Edoardo say, probably will be a DDW, but we will publish the manuscript in the next couple months. So we had 36 statements, and you will see today from the single presentation all the statements we vote. Of course, the vote was approved when we had a consensus, was the agreement was higher than 80%. That was the first vote session. And if the statement has between 20 and 80, we re-review the statement and we re-vote. If at the first session we had an agreement less than 20, okay, that statement is not going to work. So in the second round, the method was to approve if you have a statement higher than 80, and if it's not in the consensus, of course. So we are really landing because the manuscript is almost done, how I say, and probably that will be the first announcement, but you will read the paper probably before that. So I'm really happy to introduce the first speaker. They will talk about the candidacy and the pre-operative evaluation. How you saw, we decided to put together 2 chairs, one GI and one surgeon, because we wanted the 2 point of view, and that's what really I think we need for the post-operative evaluation. GI need the help of surgeon to understand what's going on, and the surgeon need the GI to understand what's going on after surgery. So thank you very much. Mario.
Okay. Thank you, Renato. Thank you, Edoardo. Thanks, Mark, for the invitation to be able to speak in front of such a distinguished audience. I have no disclosure. I'm a surgeon. So I'm giving you the point of view of a surgeon, and I will say of a function surgeon that is quite different from average surgeon. Because as my American mentors always said, if you are altering the anatomy to restore function is quite a challenging task. And I will dedicate this lecture, this presentation to this man that taught, that educated such a number of surgeons around the world. So we heard on Monday, once upon a time, there was the black and white traditional manometry, but still most of us fell in love with that, and we had also some important points from this type of procedure. Then, of course, there was the idea of Ray Klaus with tridimensional, adding the length to the pressure and the time, and we got this new technology. I have to confess that in the very beginning, to me, it was like a very nice cartoons, and I was a bit skeptic about that. But I have to recognize the willing and the strength of my junior colleague to push for having the machine in Italy. It was the first machine in Italy, and we understood that there were many aspects that were not to be seen with the traditional manometry, and so we saw things that we couldn't really imagine. And Renato said that for indication of surgery, there were already many guidelines or expert opinions, then you can see. The problem with this is that most of them, nearly all, are involving only traditional manometry studies. And the fact is that there are so many treatments now for gastroesophageal reflux that we felt the need for a good new classification, a new option to understand the candidacy and what we have to know before surgery. There were a lot of papers, a lot of discussion about the fundoplication. We have been performing fundoplication for 60 and more years now, not me, but even if I'm quite old, but there is very little about links, and there's nothing about endoscopic wrap. And of course, there was nothing about the old endoscopic treatments and the new one. Just before starting the presentation, I was impressed yesterday when I heard this movement from gastroenterologists to send the people to the surgeon for operation. This was the real world until a few years ago, I think until now. You see, the recommendation from a gastroenterologist are very, very rare, and only a few selected patients, only a few. So something is changing, and I'm a bit curious about that, a bit also worried about that. But anyway, go ahead. We already know that there are indication, no indication, potential indication. First of all, there's no indication to establish the diagnosis of gastroesophageal reflux. We have been known this for a long time, and these are the last guidelines from the American College of Gastroenterology. And HRM alone cannot diagnose GERD. Then there are also clear indications. And we see that one is the positioning of the pH impedance. Bravo can be positioned by endoscopy, looking at the Z line, but still I think manometry is good. This is a case of a friend of mine, gastroenterologist from the countryside, as I said yesterday, sent me this patient for a fundoplication, but you know, with a very pathological pH tracing. And she had a very small hiatal hernia, she had no esophagitis, symptoms are quite mild. And so I was suspicious, so I repeated my manometry and then pH monitoring, and this is the tracing. So there are some refluxes, in the night, but I mean, this is not the same as before. So, and this is acknowledged by the Lyon consensus, as you know. Then there is the exclusion of major esophageal motor disorders. This is a report from our Dutch friends, and I think, I'm sure that this happened in any surgical families. These are 3 patients that were referred by expert gastroenterologists for a fundoplication, and this instead they had achalasia. So this is the most important things to do. And you see that this is already well known by by the American College guidelines on testing. This is quite different from the other. Also, there is Icarus, a lot of gastroenterology from around the world, a little less surgeons that you can see in yellow, some Italians, and they showed something that we already know, but in a more detailed way. And it's clear that manometry and pH monitoring together are mandatory for candidacy of you know how to exclude functional harbor and rumination syndrome with manometry. I will not deal with that. But there are some potential indication, and to select which procedure you can perform for reflux. And the choice is between toupet, that is a partial posterior, and a Nissen, that is the total fundoplication. But, you know, there are many papers saying that there's no difference. I mean, the presence of altered motility on the esophagus makes no difference in the postoperative dysphagia. I think this is also because of a beta type 2 error, because dysphagia is such a little part of complication and symptoms after surgery. Let's say 5 to 7, maybe 8, maybe 10% in good hands, and so it's difficult to compare this patient. But you know, again, these papers were from the traditional manometry. This is another randomized trial, and so there's no difference. So manometry in choosing the rope is quite again and again. This is why, the last slide is why we surgeons now prefer toupet, the partial fundoplication, because it has more, less side effects, both dysphagia but also gas bloat, that are much more cumbersome for the patient and for the doctor than real dysphagia. Because of dysphagia, we can do something, we can remove the wrap, but with gas bloat syndrome, we are more vulnerable. So everyone was happy and really looking forward to this paper that came some years ago about the multiple rapid swallow to identify patients that are keen to develop postoperative dysphagia. But just recently, there was another paper from Portland group, and they show that there's no difference in patients who had adequate declutative inhibition or not. So probably we need more studies on that. Bariatric surgery will develop later on. And the hiatal hernia, this is another topic in which manometry could be helpful. We have people have been looking for hiatal hernia signs for a very long time. You see, Winans and Harris in '67, they showed that this double hump, that is the crural and the less separation, the double IRP, the length of the sphincter. So there were, but it was very, I promise you, it was very cumbersome, very difficult to see a tracing in traditional way. Of course, high resolution is better than endoscopy in choosing in detecting hiatal hernia with a higher specificity and predictive value. But this is something that is not so fair because you compare more or less physiological test with manometry with a patient supine in a good condition with endoscopy that is the most unphysiological test to assess motility. But anyway, manometry is the way to go to detect hiatal hernia. I can say something about barium swallow, but then again, the patient is made to push, to squeeze, and so is also unphysiological. Then we have this important thing that maybe can help us in detecting the real hiatal hernia. So, and it was demonstrated by the Chicago group, the no separation, the complete separation more than 4 centimeters, and the possible separation. So this will help us. So this was a potpourri of what we know now for with the esophageal manometry. And these are the statements that were at the beginning put together to be submitted to the voting. I don't know. I don't think you needed to copy them because they were available on the website. With there were some were quite simple, other were quite complex, and again and again. So we voted, as Renato said, but I will not tell you anything with the results, which of these statements were accepted and which were not. And again, we hope, we are nearly sure that we'll be able to present this classification next to DW in Washington. And I thank you for your attention.
I think Mario gave us some preview. I mean, because we probably, you understand the statement about if we need to understand the motility of our patient before going operating room, is not something that make the surgeon deciding how Sumeet yesterday suggested, but it's absolutely true, because until 5 years ago this was a really big topic. If we have a really bad motility, we have to pay. If you have a perfect motility, we can do the nascent without thinking about the postoperative dysphagia. This is, with IRES, we totally understood that is not this, and all the group agree about this, and probably that's one of the most important things for surgeon. I think that can be from functional surgeon, how Mario say, is to have the pre-operative evaluation. Some question from the floor? Maybe Edoardo, Mark, want to, the GI part, say something?
I mean, I would caution about this because, first of all, with I mean, there's no argument that the manometry is going to be done. And I think if you're going to operate, then you have to exclude achalasia and occasionally other major motility disorders. But I think the key reason why this doesn't appear to be so important anymore, the ineffective motility, are two things. One thing is that now we realize that water swallows are not adequate to assess the situation alone. And we have to do provocative tests, and one can discuss which, but I like solids and other people prefer other technologies, methods. But the other thing is the change in surgical practice. In the past, Nissen fundoplication, which is clearly causing more of a functional obstruction, was the primary method. And now most surgeons seem to favor toupee as a decent compromise between reflux protection and a lack of dysphagia. So I think there's this complex interaction here. But I mean, speaking personally, I've seen many people who've had dysphagia post-operative and who had pre-operatively ineffective motility, but fair enough. these are mostly people that have undergone Nissen fundoplication. And I'd like to see that nuance brought out in the Padua classification when it's published.
Yeah, we have to wait and see if this will be true, because I mean, dysphagia is nearly always related to technical difficulty in make a wrong rope with. You know, there was a surgeon in Italy that made Nissen after myotomy for achalasia. Everyone was against him, but the results that he had were quite good, as good as the other in the world. Anyway, the problem with the Toupet and Nissen is also related to the results of some randomized studies. There was also, Daniel, that was a randomized study that, but you know, a randomized study, when you perform a randomized study, you are in a hurry to publish the results. So we have 2 years results, maybe we have 5 years results, we don't have 10 or 20 year result. And since it demonstrated that the side effects are less important than with the Nissen, most surgeons do that, but not for fear of dysphagia. I said again, the patient that we were talking yesterday about the bucket, the difficult patient, I will always perform Toupet now for this reason.
Mario, it was not clear to me in your presentation. On the one hand, you said that tailoring is not necessary. And on the other hand, you said, we decided to do Toupet to everybody.
Yeah.
It sounds to me a little bit contradictory, because if you decide to do Toupet to everybody, it's because somehow you are afraid of the possibility of dysphagia.
I understand. You are right, Daniel, but the problem is that I'm not choosing Toupet and Nissen based on motility. I'm not afraid of dysphagia. Dysphagia is very little, very, I mean, it's a small percentage in the good hands. The problem is gas bloat. There are some gastrointestinal disturbances after surgery. And this feel very, very bad, the patient and the surgeon that has the patient every second week in the office. And so this is why most of people, I would show a graph in our experience from the 90s to now. In the beginning, we performed the Toupet in 10% of the patient based on ineffective motility, as we called then. But then we increased the number of Toupet because of this, but still independently of ineffective motility. I've been curious. I'm curious about provocative tests and the leg rising test and the solid swallow and so on. So we need some more studies about that. This is a potential indication for before surgery. It's not a clear indication before surgery, in my opinion, and in the opinion of some literature that you saw.
Nir from Israel. Thank you. That was very enlightening. And without disclosing your vote, what kind of tests would you have your patients do before fundoplication, and how would you treat it? You may have already half answered my questions already, but...
you know, the candidacy statements, as Renato said, didn't reach the consensus. So there's no consensus about which test to perform before, I mean, normally, how to indicate function surgery. In my mind, I can't say never, but very seldom I operated a patient without manometry and without pH monitoring. Nearly all had also bariatric swallow and, of course, endoscopy. Sometimes also gastric emptying, but gastric emptying is so difficult, so variable, and there's no reason to do that. But, of course, manometry and pH monitoring, now pH impedance, of course, and the other test.
So that's another preview. We don't need, I mean, in this moment, there's no agreement about to do a provocative test before going in operating room for anti-reflux procedure to decide which fundoplication we have to do. In this moment, of course, how John say yesterday, we need to improve the research in this topic in this way, and we don't have a big number. That's what the literature show us, and the working group analyze all the study present in this moment. I think there's some question upstairs. Oh, sorry.
Hi, I agree with you regarding the provocative tests and preoperative assessment. And I'm just sort of, I'm from the Adelaide group where, we've had a long, more than 20-year history of doing 7 randomized trials with partial, 90, 180, 270, 360. And I think it always comes back to preparation of the patient. I don't think people are so nervous about dysphagia now. Preoperative assessment, what's the key thing that most surgeons want? They want to know whether you've got typical reflux symptoms. They want to know whether you've got a response to a PPI because that gives you confirmation. And they want objective evidence. They want either endoscopic or pH impedance, something to confirm that you've got a patient who's actually got reflux. We all know that some patients have dysphagia before surgery. It's the most predictive thing of post-operative surgery. However, I think we may need to keep two things in mind, and I don't want to jump ahead because the post-op's coming, but everybody settles down at 2 years post-op with a sort of a certain level of dysphagia or resolved. I think the example of the achalasia patient who had a Nissen gives us another window to sort of keep an eye out that it's education, understanding. An achalasia patient will tolerate mild dysphagia. A reflux patient may not tolerate mild dysphagia unless they're educated. So I think we need to sort of, until we got more evidence, we need to hold it in context.
That's why I was so happy in seeing the Icarus guidelines, because all these gastroenterologists lately just made order in something that we already know from previous very little studies from Guillermo Campos, for example, from the Mister group again. But Icarus clearly showed the indication for surgery in patients. So this is one of my favorite paper.
Sumeet, I think.
Okay. I just would like to say that I think what we forget in this, that as a surgeon, a toupee from one surgeon is not same as a toupee from other surgeon. Same with the Nissen. And it's actually not the same procedure I did 20 years ago to what I do now. So I think we underestimate that what a variation in the obstruction or the barrier that we are creating and how is that affected. And that's probably one of the reasons we cannot come up with consensus issues. I think everybody said now the dysphagia is less of an issue. I think it could be partly because we are doing a better job at surgery, could be better, we are preparing the patients better, but I think it's less of an issue now than it used to be. But in my experience, the single biggest factor of predicting post-operative significant problem is preoperative dysphagia, and to an extent, if on barium swallows supine, I notice the barium doesn't go down. Manometry really does not, at least in my opinion, help much, and that's what John also said yesterday.
Yeah. I agree that there was an improvement in technical aspect. For example, in our experience, after the first 50 fundoplication, we decided to cut the short gastric vessel that before we didn't, and we had a drop in the dysphagia. And then there is also the learning curve. That is not a personal learning curve; it's an institutional learning curve, because the younger take advantage of the tricks and the tips of the older. So this is another important point.
I absolutely agree with you, Sumeet. That's what we needed to do, to clarify this question, because you are the Mr. Fellow, and probably you are born in this way. If you have a bad motility, it's better we do a toupee. If you have a good motility, you can have a 360-degree wrap. So absolutely, that was one of the main aim of the project. John, and after...
Well, just real quick, not to beat a dead horse, but I think if we're going to move the needle forward on all of this, we've got to get away from the knee-jerk reaction of recommending manometry for every patient that's going to have surgery. The data's not there to support it. We've been doing it for 40 years, and it doesn't help us tailor it. So I think a major step forward in this classification and any classification going forward is to get out from recommending manometry for every patient. The data isn't there.
Indication is to rule out major
I
motility disorders.
totally disagree. I think you can adequately rule out achalasia
Yeah, that's by
at
barium
any
swallow.
major by barium swallow and combination of EGD, and we publish that.
No, there's so many data that don't support that.
Refer back to my publication from 3 years ago.
And there's multiple publications suggesting that barium swallow is only about 60% sensitive to achalasia.
Exactly. Yeah.
So the problem is that
And the thing is, in the best centers, these mistakes don't happen. But it's what you say about the countryside.
Yeah.
You know, there's stuff
the
that's
problem
happening.
is, John, the problem is that then some patients come to our or other big department to be fixed because something went wrong because of the omission of manometry and the function study.
Yeah.
This is quite a normal practice in my office. There was Vasily.
Thank you. I would like to ask another point in terms of the selection of the anti-reflux surgery. There are a few studies showing that psychiatric comorbidities actually affect the outcome. And we see it a lot. I work very close with psychiatrists, as close as the surgeons actually. And we see many somatization disorders or anxiety disorders with or severe reflux disease, and psychiatrists just recommend to postpone the surgery for a while. In which extent and when do you consult the psychiatrist, your anti-reflux surgery patients, because outcomes are pretty bad if there is a severe or somehow a psychiatric comorbidity in those.
Yeah, I completely agree, and I will be short. You don't need a psychiatrist to understand that the patient is something particular. And first of all. Secondly, I was always very scared about putting the hand on this particular patient. I did some after complete evaluation with the sure reflux, erosive esophagitis, manometry, and so on. But in these are the patients will do always to pay fundoplication. Never the Nissen.
I think it's very nice to have these statements, but I think that those are very esophageal centered. So because there should be some other considerations, for example, overlapping with dyspepsia, nausea, persistency of nausea before surgery, and also gas and bloating. So those patients are the worst you can see after a fundoplication, and so I think that those measurements to assess gastric emptying or evaluate the symptoms are also very necessary to take into account.
I think the clinical evaluation is the key, because the gastric emptying did not show any interest, any results in evaluating this patient. But it's true, patients with IBS or functional dysphagia have much more complication, gastrointestinal complication, than a patient without these syndromes.
Yeah, I think we should move on. Before move on, just a short question to John. Do you believe that EGJ outflow obstruction, distal esophageal spasm, or hypercontractile esophagus is a contraindication for doing Toupet or Nissen fundoplication?
I think many of the EGJ outflow obstruction and even spasm is caused by reflux. I don't think it's necessarily a contraindication. I think there's a select portion where it will probably do more harm than good. So it does need to be.
But cannot be seen using esophagogram or upper endoscopy, right?
The barium swallow doesn't show delay at the G junction. I don't care what the manometry says about EGD or So, that's been the case for 15 years, not just after Chicago 4.0. So, I think a barium swallow is an underappreciated tool in our current society right here.
Just one more comment for everybody. Just as homework, we did publish a series of 400 patients that got barium swallow for a set protocol and manometry. And what we showed is that if the barium was normal, it never missed any major motility disorder of the esophagus.
We will just have to agree to disagree.
Yeah. Yeah. There are many other evidence that this says the contrary. The problem, Tom, is also that Barium swallow is disappearing, is in an endangering.
But that would be a shame. To make it disappear would also be a shame.
Yeah. And now it's the turn of Jutta Keller from Hamburg. Thank you, Mario. And she will talk us about Padua classification of HRM following Fundoplication, and after Jutta, Sumeet will talk later.
Thank you very much, Edoardo. I have to find our talks first, but I did.
You have found it.
I found
think
it.
you've closed off the...
Oh.
The projector's switched off.
Okay.
It was too long.
Yeah. So I'm going to present the results of our group. Actually, I'm going to present the first part of the results of our group. We are talking about the role of HRM post-fundoplication in patients with fundoplication failure. And you've already seen the beautiful slides by Renato showing this aeroplane, and we are one of the groups in the aeroplane, group 3. And as those of you who are familiar with international and national guidelines know, the first task for every guideline group is to pose the correct questions. And our questions were so complicated that I need the presentations to read them out to you, so we'll have to wait by now.
While we're waiting, can we just jump back a little bit? The adynamic or the aperithaltic esophagus prior to surgery. Did you have a discussion about how to handle the preoperative workup for an adynamic or?
At the present, there's no evidence that with the peristaltic esophagus you have to skip the fundoplication. You can make a partial fundoplication.
Yep.
We are. Please, Jutta.
Okay, back to the questions. The first question was which HRM findings regarding the LACD configuration are expected after successful fundoplication? The second, do normal post-fundoplication HRM findings differ according to fundoplication technique? Then can different types of failure be characterized manometrically? And is the EGJ anatomy morphology important in distinguishing different mechanisms of outflow obstruction in post-surgery patients presenting with dysphagia? Can fundoplication-related outflow obstruction be diagnosed reliably by a single or a combination of HRM parameters? Are complementary non-manometric investigations required in patients with normal endoscopy findings for confirmation of either reflux disease, recurrent reflux disease, or fundoplication-related outflow obstruction? And what is the recommended HRM protocol in symptomatic patients after fundoplication? And finally, can the manometric assessment be an indication or contraindication for retreatment? And those marked in blue, they relate to the general role of HRM in fundoplication failure and expected normal findings. And for those, I'm going to present what our recommendations and the statements. I'm going to present some statements, but not the final results of the Padua classification. And the complicated stuff, what you can see after when fundoplication has failed manometrically, that's what Dr. Mittal is going to present afterwards. We reordered our questions. I'm going to start with, can the manometric assessment be an indication or contraindication for retreatment? And can fundoplication-related outflow obstruction be diagnosed reliably by HRM? Well, we know that from multiple studies that HRM can characterize esophageal motility and EGJ junction morphology and function, and it can do so in after fundoplication as well as in surgery-naive patients. It is important in patients with persistent or new onset reflux symptoms and or dysphagia. and it may explain mechanisms of post-operative complications and treatment failure. It can differentiate between EGJ outflow obstruction and other causes of dysphagia, for instance, absent peristalsis, and therefore may guide treatment. There are exceptions to this rule because patients who have a large hiatal hernia, which necessitates operation anyway, they do not need further investigations. And there is no, you can search the literature as long as you want to, there is no indication that a specific HRM finding could be used to, as an indication for reoperative fundoplication. Therefore, these are the statements we proposed to the total group. We recommend performance of HRM in patients with unsuccessful fundoplication, which means persistent or new onset reflux symptoms and or dysphagia, as an integral part of the diagnostic workup, unless a large recurrent hernia necessitates reoperation. And no manometry finding is an absolute indication for the need for reoperative fundoplication, but HRM plays a role in decision-making when used in adjunct with endoscopic pH monitoring and barium studies. And throughout the Delphi process, these statements were more or less confirmed. It was shortened a little bit. HRM has a diagnostic role in patients with unsuccessful fundoplication and persistent or new onset reflux symptoms and or dysphagia, and the exception are the large hernias, and the other statement was confirmed in the original way. The second question related to complementary non-manometric investigations required in patients with normal endoscopic findings. And of course, 24-hour pH metry and impedance allows for objective diagnosis of GERD also in patients post-operatively. Time barium swallow and flip may help to identify patients with clinically relevant outflow obstruction. This, therefore, it has been suggested as an adjunctive investigation for corroboration of clinical relevance of outflow obstruction by the Chicago 4 classification in surgery-naive patients. And it makes sense to also use it in post-operatively. However, it has not been tested specifically in patients with failed fundoplication, flip at least not, and there are no normative post-surgery values for flip in post-operative patients still. The recommendations of the group were documentation of recurrent reflux with adequate pH monitoring of PPI, plus-minus impedance. Measurements is essential or mandatory in patients with an endoscopically normal fundoplication. And in patients with new onset dysphagia and normal endoscopic findings, timed barium swallow and functional luminal imaging probe technology may help to clarify the etiology of symptoms, in particular if manometric findings are normal. And again, these statements have been slightly modified. There are no manometry finding is an absolute indication. You've seen this before, and the inclusion of pH metry and reflux monitoring has been included in adjunct with pH monitoring in this statement. And the other one was confirmed throughout the Delphi process. What about the expected normal findings after fundoplication? Well, there is a study by Weinborg and colleagues who showed that asymptomatic patients who had neither reflux symptoms nor dysphagia and normal barium swallows 3 months after fundoplication invariably had a single high pressure zone. The LES values, including the IRP, were higher than preoperatively. That's what you aim at when doing surgery. But they had a normal passage to the stomach according to the barium studies. And this is one of our patients which we investigated at the beginning of the year, around about 11 or 12 years after Toupet fundoplication. And you can see this beautiful single pressure zone going up and down with respiration, with a normal mean basal pressure of 26 millimeters of mercury. Our normal values are between 10 and 35. And a normal IRP with 6.5 millimeters of mercury. So the recommendation of the group was HRM findings after a successful fundoplication show a single distal high pressure zone reflecting normal LES-CD configuration with appropriate deglutitive relaxation. And this was also confirmed during the Delphi process. Now, what we've just discussed, do normal post-fundoplication HRM findings differ according to fundoplication technique? Well, there actually are only a few studies which really investigated this question. The largest one is one from our group, performed in 200 patients altogether. One operated according to Nissen and one according to Toupet, but it was done by conventional manometry. And there are two other studies, the one by Weinberg I've already presented. They included 20 patients operated on according to Nissen, and 20 had a partial fundoplication. And a new one published last year in the Annals of Surgery by Müller and colleagues. They had a larger portion of patients, 37, something like that, operated on according to Nissen, and 15 roundabout operated on according to Toupet. And we showed, together with the other studies, that after the Nissen fundoplication, you can expect higher EGJ resting pressure, higher IRP, higher DCI, if you do high-resolution manometry. And this might be due to the tighter wrap, because this induces a stronger peristaltic response. And you have two beautiful examples from the Weinberg paper over here, showing the higher resting pressure after Nissen compared to Toupet, the higher IRP you can see over here, and the higher DCI, which can clearly be seen. And the normal values for the IRP were higher than you expect in non-operated patients after Nissen. It was 5 to 24 millimeters of mercury, with 24 millimeters of mercury being the upper level of normal in their study, whereas after Toupet fundoplication, it was actually what you expect in surgery-naive patients. It has to be said that Müller and colleagues did not find significant differences for IRP, but still the group recommended that Nissen fundoplication tends to be associated with higher EGJ resting pressures, higher IRP, and higher esophageal contractility compared to Toupet. The latter may not only be due to higher resistance at the EGJ level, but also to tailoring the type of fundoplication to pre-existing motility patterns. And this was more or less confirmed during the Delphi process, and that's what I wanted to show you, the easier part. Yeah?
This is...
We have the same problem than before. I don't know what's going on.
I'll just close this completely first. Let's just close it completely. Go to Wednesday. Go to
that one. We make the question in the end when also Sumeet presented, so we can have a discussion between GI and surgery in this topic.
There's something funny going on today. It's not. It's something. There's something really different suddenly.
Right. Yeah. So this is part 2 of the post-fundoplication manometry. I'm Sumeet again, and I thought I'll first just show that what do we mean when we are using the different terminology, at least in my mind, of the slipped and intrathoracic or a twisted fundoplication. So starting from the A, this is what we look at a normal fundoplication. There are 2 tuck scenes symmetrically around the scope, and then if you're a Toupet, it's going to be a little looser. It's an omega valve versus a very tight valve. Then B is what I would call, previous slides, I'm sorry, previous B. Yep. So that is an intrathoracic fundoplication, meaning that the fundoplication is around the esophagus, but the whole complex has gone into the chest. C is a slipped is a partially disrupted fundoplication that either the posterior or the anterior limb has become loose, so it's still around the esophagus. Everything is below the hiatus, but it's just looser than what we wanted it to be, like in A. D is a twisted fundoplication, which basically a fundoplication means you've taken the fundus and wrapped it around the esophagus, but if you take the body, it is going to look really twisted. Fortunately, we don't see that very commonly now. I think it was a learning curve of the whole surgical community that we are seeing less and less of that. E is basically a slipped fundoplication, meaning that the wrap is actually on the stomach and not on the esophagus. And on antegrade view, you see like it's a sliding hernia or maybe sometimes bigger. And on retroflex views, you see the folds, but you don't see the esophagogastric or the retroflex view, the SCJ in patients without Barrett's. And then that's a paraesophageal hernia, which basically a part of the fundus has gone above the hiatus, but the fundoplication itself is below the hiatus, and it's still relatively intact, and these patients may have a different set of symptoms. So after the statement 5 statements Dr. Keller spoke about, these were these statement 6. And again, I'm not allowed to know the results because frankly, I don't even remember them. But a very prominent, that was an honest answer. A very prominent single high pressure zone with impaired or failed degustative relaxation can indicate a twisted or a too tight fundoplication. And this is a picture of a twisted fundoplication and a manometry. And you can see that usually, I would operate with something else, without a manometry, but never without a barium swallow. Just, that's my opinion. And so this is a twisted fundoplication. You can see the extra fold on the barium swallow. This is the cartoon representation of the SERM. This is an endoscopic picture. Clearly, you can see that it's just trying to twirl around. The IRP is usually, it's very high, doesn't relax, and there is a little bit of, intrabolus pressurization, but intrabolus pressurization is the part of second statement, which is number 7 statement, is that if you have a high IBP and a high IRP, then that may be a problem with post-fundoplication outflow obstruction. So I hope the PFOO is not as controversial as EGJOO and cause as much problems, and we'll be smarter about it, but that's the statement 7. This is a fundoplication. The IRP is a little higher, but this, the normal values, it was surprising that how little normal values that we have, but I didn't really have a picture of a very normal-looking fundoplication with a very high IRP and an intrabolus pressure. The statement was that a combination HRM findings correlating with a slipped fundoplication include a dual high pressure zone. I think the biggest thing we learn is that a normal patient will always have a single high pressure zone as compared to, if it's a double high pressure zone, then it's always something wrong. And basically the high pressure zone can be 2 because of either the whole wrap has gone into the chest or the G junction has gone and the wrap is on the stomach. So basically what this statement said, and this is the slipped fundoplication, that if you have 2 high pressure zones and the top one relaxes and the bottom one does not, it basically means that the fundoplication is at the level of the cruise and it's a non-relaxing fundoplication. Probably it made a lot more sense to me back many years ago. I didn't even change the bottom of my slides, it looks like. But that's where a slipped fundoplication would look like. You can see that this is the lower esophageal sphincter, the native sphincter, which has gone into the chest right here, which is right here. And on the fundoplication is the level of the cruise. And a slipped fundoplication usually does not relax, derogative relaxation like we saw. Statement 9 is that if you have a double high pressure zone, but the bottom one is a respiratory pattern and the top one relaxes or not relaxes, then basically it's an intrathoracic fundoplication that the whole wrap has gone into the chest, and this is the stomach that's herniated with the hiatus. So this is the fundoplication, and this is the hiatus, and on retroflex view, which is a relatively intact fundoplication inside, and then this is the cruise. So you will see the fundoplication, and that depending on how tight or loose it is, it will have its relaxation and how tight it is. But the diaphragmatic hiatus, because by definition it's going to be wide, you will see that separately with respiratory variations, and you could distinguish them. This is just a larger intrathoracic stomach that it has gone up, and this is the diaphragmatic hiatus there. And then because the wrap is somewhat more disrupted, or it's a partial wrap, the basal pressure is less than what we saw in the last one. So again, more than one problem can occur, but pretty much the conclusion that we got is that if you have a double high pressure zone, it is abnormal. And a high IRP is abnormal, but we just don't know what the cutoff should be, whether Toupet and Nissens are different. And then a low IRP may indicate a weak fundoplication, but really don't know what that means either. So I think I already released the answers without giving the answers. So.
So we call Jutta too. So Sumeet gave us probably the main results. I mean, the classification we start. No, that's absolutely. The classification we start with the analysis of if we have one high pressure zone or if we have two high pressure zone. After, we have to understand which is the native LES, which is the fundoplication, which is the crura. So that's how the classification moving to understand what's going on. Roberto, I think.
Yeah, thank you very much. Very, very nice. And I agree on what you summarize. Renato, one of your statements, Jutta, if I got it right, that in symptomatic patients, HRM and pH and reflux testing are indicated unless endoscopically normal fundoplication. This last part is, to me, very strange, because not all endoscopists are very careful and know exactly how to grade. And what does this mean? That if you have an endoscopy and you don't have photographs, the first thing is to do another endoscopy by an experienced endoscopist? And if this is normal, you don't study a symptomatic patient?
No, it is not an exclusion criterion. We wanted to stress that these tests are especially necessary in patients whose symptoms are not explained by endoscopy, but but it's not an exclusion criterion.
Okay.
There.
Because this is, needs to be written
very
carefully, because otherwise we just assume, like the barium swallow, that now is not done very well in many places. I mean, that this is rules out a problem or functional testing.
Hi, Charles Cock, Adelaide. I'm a gastroenterologist. I'm like a psychiatrist, but with an endoscope. In terms of your statement 7, I just want to raise the issue that if you are going to increase the outflow resistance, the intrabolus pressure has to increase in order for the esophagus to clear. So that's not necessarily abnormal. That may be a normal response to the fact that flow resistance is increased and the esophagus is increasing its contraction in order to clear the EGJ.
I think we'll have to come with different normal values for once we come up with a new normal or expected IRP cutoff for a fundoplication patient. Similarly, I would assume a higher IBP that would be required. Unfortunately, actually, me and we were all discussing that, that IBP removal from the Chicago classification we thought was a step backwards.
Yeah.
So we want to make sure that it becomes part of our classification.
First, and second, also some company take off the IBP from the report, so now it's impossible if we want to make a normal value, and that's we discuss a lot about it. It's really impossible to have it, but. Just yesterday we talked about the Chicago 5.0. Probably we need to try to re-include again the ABP to the preoperative evaluation. Yep.
Okay. Thank you for this important project. My name is Amir Murray from Nazareth, Israel. I have a question to you, Renato. In the first slide, you presented that you also cover bariatric surgeries, but we could not see any of...
Yes, the next presentation is Salvatore. Is going the both pre and post-operative bariatric.
Because nowadays we see more commonly post-operative bariatric patients. Thanks.
I have to tell you, I'm coming out now. The main problem in my mind when I started this project was that in Italy, but probably in other country, we can perform IRS after surgery with a normal follow-up. I mean, in my clinic, the normal follow-up was 6 months after surgery. You call the patient back, also if the patient is totally asymptomatic, and you can perform the manometry. I know I was in US for 1 year. That in US is not possible at all. So when we started with the classification, in my mind was we need to understand and give the patient the normal findings for fundoplication. But I changed it with all the group together. I changed my mind during the project because we need to understand what's going on if the patient is symptomatic, not if the patient is not asymptomatic. So that's why that's the topic. Really, I learned a lot from the international working group to change my mind before the project. And Sumeet was probably one of the biggest help.
Most people don't appreciate getting another manometry just for fun, you know. So
no, absolutely.
That's one of the reasons. Second, insurance doesn't cover it, and even if we found money to cover it, me and John were talking. The hospital charged an exorbitant amount for any research studies. So it's just like completely, number one, torturing the patient, and then it's way, way too expensive than what it could be. The hospital just won't let us do it. So.
Please.
Hello, I am Emanuela Tsoukali from Greece. I would like to ask if you have concluded to your statements about intraoperatively use of HRM or endoflip, if it helps to the results.
I don't think that was part of any of our statements. That's a very important question. I think maybe part of our 2.0 in future, or maybe we can add it even now. We have a whole year.
No, I mean.
But we might comment on it in the manuscript.
That's a good idea. Thank you.
I have a concern about what you call a normal subject post-operative, only based on absence of symptoms. I must say that I would be much confident if the patient does not have symptoms and there is a good flow of barium or impedance in the HRM, and the reflux monitoring is completely zero.
Yeah, so actually this is the criteria that's used by the Dr. Swanstrom group with the normals. I'm not, remember the other ones, but they have pH monitoring, those who are normal, and on the barium swallow they had good flow, and a totally asymptomatic patient. So again, yes, you're absolutely right, that has to be there, and that is part of the papers that we're reviewing. But there's so little data, you just can't exclude the ones that don't have it.
Yeah. And
so Mark Stroke's
and one of the study we performed 20 years ago showed that at least half of the patients who appear as asymptomatic still have pathological reflux afterwards. So that's an important contribution, but those studies usually had a look at that.
Mark Stroxler, Zürich in Adelaide. That's a question for Sumeet. I obviously appreciate that we need to know what the manometry looks like, in a slipped fundoplication. But the picture, the endoscopic pictures you showed, if your fellow shows you this, you're going to plan revisional surgery. So what does the manometry really add in this situation?
If you'd asked me that question 10 years, I would have defended myself much more. But again, I think the biggest reason to do a manometry, in my opinion, is to rule out achalasia. And, especially if the patient never had a manometry before the first surgery. If I'm going to do a second operation, and we know that with every repeat operation, the morbidity and the outcomes are progressively getting worse, so I would want to get some assessment of the esophageal body, which, I know is not a very great way, but again, just to see the visual that there is peristalsis, whether the nuances of a slipped versus, I think the reason for a classification also may not be just to say that, we have this type of failure, but can we predict that if we do a certain type of surgery, what will be the outcomes? I do see that patients with slipped fundoplications are more likely to have a short esophagus as compared to, some of the other failures, maybe, and that I used to think at least. Two is that now there is more than one alternative for a reoperative intervention besides just the fundoplication, roll-up Roux-en-Y reconstruction. Do we know that there is any particular patients that will do better with a Roux-en-Y reconstruction than with a redo? Again, those questions can only be answered once we start classifying people in different buckets to follow them up. I think that'll be the biggest reason rather than per se.
And maybe,
in my opinion.
Pictures were fantastic and unfortunately rarely so beautiful.
Yeah, and let me add from a gastroenterologist's point of view, we do see patients who have actually normal endoscopic findings, but dramatic changes as soon as we give solid boluses with clear obstruction at the level of the fundoplication. So we do post-operative manometry also for these reasons, because we find patients who cannot be seen endoscopically.
One last
identified
short comment, Roberto.
Yes. Which is your strategy to collect the normal findings if there are problems to do studies in those who are asymptomatic? Because this is really very important to get.
I'm not able to do it.
So from the countries where you can. Yeah. Okay, and then that's it.
Well, it's getting harder and harder for us to do it. And so we had some questions. We're done?
Yeah, we're done.
Okay.
Okay.
Thank you.
Thank you.
Thank you. Now the last speaker is Salvatore Tolone. Is a surgeon. He's coming from University of Naples, and he will speak about physiological evaluation prior and following bariatric surgery. This is another important topic. So, Salvatore, please.
Thank you very much, Edoardo, Renato, and Mark. Thank you very much. It's really for me a big honor to be here to present our work. These are my declaration. I will go faster on the introduction slide because we all know the effect that obesity can give on the gastrointestinal system, and especially on the esophagus, on the esophagogastric junction. We all know this cardinal study by Ayazin, in which we clearly see that increasing the BMI, we have the lowering of the EGJ tone and increasing exposure to the acid into the esophagus. And also another cardinal study from 2006 that Pandolfino and Carlos showed us that obesity probably is not a challenge, but it's a terroristic attempt to the integrity of the esophagogastric junction. And we also know that central obesity is a huge risk factors also in asymptomatic volunteers, in which we have the less shortening, also in asymptomatic, and we have an acid exposure linear increase in overweight and increasing the BMI values. But on the other hand, we also know that in this beautiful study from Nicola de Bortoli, that the weight loss can help us to reduce symptoms and also PPI's consumption. And this is one of the principles of the bariatric surgery. Also, we know that performing bariatric surgery, we have to drastically change the anatomy and the physiology, because we will see that all the bariatric procedure we actually do will have an anatomic remodeling of our stomach, so probably of the physiology. I will go actually to the prior bariatric surgery proposed statement. We just know that these are the final statement, but we don't present the vote. So systematic preoperative high resolution manometry is not recommended prior bariatric surgery. Preoperative high-resolution manometry should be performed in presence of esophageal symptoms. And preoperative manometry can be used to define the EGJ morphology and measure LES relaxation and resting pressure prior to bariatric surgery. Preoperative esophageal HRM findings can be used as additional parameters to refine GERD or motility disorder diagnosis, but not to predict postoperative GERD or dysphagia. The transdiaphragmatic gradient is not a feature of GERD and can be reduced after weight loss, so its role in being relevant prior to bariatric surgery still needs to be investigated. And finally, given the high prevalence of the AGJ outflow obstruction diagnosis in the morbidly obese, a comprehensive evaluation for distinguishing true esophagogastric junction obstruction from artifactual one with multi-rapid swallow and rapid ink challenges should be performed. The recommended protocol in Chicago classification version 4 will be best suited for the bariatric population for preoperative assessed when indicated. So discussing this statement, we have some concerns. because we actually know that obese are exposed to a decreased esophageal sensitivity to the acid. So also the performance of the definition of GERD using the monoreal consensus is difficult in an obese patient because we have that up 1/3 of this patient are totally asymptomatic. And also previously was showed that there are a part of the obese that are exposed to the so-called silent GERD that is hugely linked to the de novo GERD symptoms development, especially after sleeve gastrectomy. What about the incidence of this motility? We can see in this beautiful paper by Chris and Schopman that up to 1/3 of patients can have motility disorders according to the Chicago classification version 3. And we have 18% of EGJ outflow obstruction, but with symptoms in 1/2. Jackhammer esophagus in 7.5%, symptoms in 1/3. This esophageal spasm in 4% with symptoms in half of patient, and only ineffective motility in 2% with symptoms in 1/3, and fragmented in 1.4% with symptoms in 1/2. But this is a little bit in contrast by data showed us by the group of Prakash, in which we have a lower percentage of outflow obstruction, a greater percentage of hypomotility in the obese, and probably because they are linked to the GERD, and also the symptomatic burden is more linked to the acid and not to the motility, to the dysmotility present. What about assessing the EGJ in the obese with high-resolution manometry? We studied the performance of the high-resolution manometry in comparison with upper endoscopy, in comparison on Barron's wall, and in comparison in vivo, and we really believe that high-resolution manometry is, as Mario said, is the best physiologic evaluation that we can have for type 1 sliding hotel hernia with a best diagnostic performance. A group of Paola Iovino and Gigi Angrisani also performed this similar study, but in the obese with another reference in vivo during the intraoperative period. And the sensitivity for high resolution manometry was really high, 90%. But with a decrease of the specificity. And we just know that having a preoperative diagnosis of hiatal hernia can be important also to check the correlation with a possible positivity with pH monitoring or pH monitoring. Also, high-resolution manometry, we know that can be used as adjunctive parameters for the Lyon consensus, and also, again, the group of Chris and Schopman provided us very important data, also in a symptomatic group, in which we had 1/3 of positive GERD, confirmed GERD, and 40% of borderline GERD, in which high-resolution manometry was really helpful in distinguish conclusive GERD versus non-conclusive GERD. We also tried to test these more or less 10 years ago, and we classified 140 obese of therapy with clinical symptom scores, with upper endoscopy and pH manometry and pH monitoring. We have an high percentage of obese with positivity of symptoms, with a positivity of upper endoscopy, like as presence of hiatal hernia and erosive esophagitis. And we see that in this group, we can have a greater incidence of sliding the hiatal hernia at high resolution manometry, a decreased pressure of the EGJ junction, a decreased percentage of normal peristaltic ways, and also a decreased completion bolus transit at impedance. So is high-resolution manometry predictive for developing GERD symptoms after sleeve gastrectomy? Actually, we don't have data about this, but it seems that the only parameters that can be predictive of developing GERD is a positive pH monitoring prior to bariatric surgery. What about AGG outflow obstruction? We saw that it can be frequently present in the assessment of the obese prior to bariatric surgery, but when enrolling this patient and evaluating with the Chicago classification for protocol, then this percentage is totally lowered. And as you can see here, this is one of my traces in obesity. You can easily see the elevated intragastric pressure, the intrabolus pressure, but at the impedance, we have a total normal transit through the junction. Finally, for the prior bariatric assessment, the transdiaphragmatic pressure gradient has probably a central role in the pathophysiology of a GERD because it correlates with abdominal circumference, not very well with BMIs. However, we don't have data after the role of transdiaphragmatic gradient after bariatric surgery, so we should wait for new data. Then we move to the part after bariatric surgery. This is a panorama of not all the technique we still can use. You can see that most of them are easy to perform by an average surgeon because we have to remove the stomach without a lymphadenectomy. So with electric scalpel, with harmonic scalpel, with stapler, it seemed to be easy. It seemed to be easy to perform one anastomosis, but we have to face this. This was one of my last patients. So there is a little bit difficult in performing this surgery. And also, please, when you do an high-resolution manometry in this patient, then I think it's easily to have a lot of artifacts. And also there is another bias for the assessing the function after bariatric surgery because we can't really standardize well what we are doing. Sleeve gastrectomy, for example, is not the same, but not in comparison with me and another surgeon. Probably it's not the same always in my hands, because sometimes we have that the stomach removed can vary in dimension. As you can see, this is a stomach reference to my abdomen. It's my abdomen and plus a part of my thorax. So we have a lot of biases. What about the proposed statement? Following bariatric surgery, high-resolution manometry should be proposed only in symptomatic patients without any evidence of obstruction, normal endoscopy on barium transit, regardless of type of bariatric surgery. Esophageal manometry by itself should be not utilized to diagnose post-bariatric GERD. Currently, there are no data showing significant correlation between postoperative manometric values and presence of abnormal acid reflux and/or reflux symptoms. After bariatric surgery, some cases of severe motility disorder have been described, such as hyperistalsis and elevated intragastric pressure with or without preserved LES relaxation. Following lap bending, there might be a significant increase in LES resting pressure with a reduction or relaxation and/or increase in high pressure zone length at the esophagogastric junction, which may be related to a misplaced bend, too proximal. Following laparoscopic sleeve gastrectomy, there is an increased intragastric pressure related to fundus removal, which may lead to de novo or worsening GERD symptoms. Some motility and pH studies are available in asymptomatic patients following sleeve gastrectomy, but to date more data is required, and non-normative values can be used as references for post-bariatric patients. Following laparoscopic sleeve gastrectomy, there can be a decrease in LES, resting pressure, DCI, and IRP, and possible reduced lower esophageal sphincter length, especially if the gastric staple line is too close, less than 1 centimeter to the esophagus. We study a huge cohort of patients with a different type of bariatric surgery, also balloon, gastric bending, sleeve gastrectomy, mini gastric, that is single anastomosis gastric bypass, Roux-en-Y, and biliopancreatic diversion. And we saw that the most exposed intervention to reflux and dysmotility is the sleeve gastrectomy, whereas Roux-en-Y gastric bypass and also one anastomosis gastric bypass can have a reduction in reflux episodes with normal preserved peristaltic function, as you can see the drop after sleeve gastrectomy in normal contractility peristaltic. What about bending? A normal placement of bending creates a double high pressure zone. In my opinion, is like having an intra-abdominal hiatal hernia. This is a personal opinion, so this is why I don't perform any more lap bending placement. So normally you should see 2 high pressure zone, whereas you can have dysphagia because of non-relaxing gastric bending, or you can have also this motility caused by the outflow obstruction resistance offered by the bending because it's too filled, too calibrated. Roux-en-Y gastric bypass should be the best anti-reflux procedure because manometrically it can create a common cavity effect, so the acid should drop into the alimentary limb. However, it seems that it cannot be defined anymore our silver bullet against GERD, because there are some reports that are assessing PPI's assumption up to 40–50% of not improved GERD and up to 60% of pathological pH monitoring. So this report are still concerning me, and especially what to do in a patient with GERD after Roux-en-Y gastric bypass. Sleeve gastrectomy, we know that can really expose it to pathological reflux. We have reports of de novo Barrett esophagus reporting from 5% up to 18% 5 years after sleeve gastrectomy. Recent meta-analysis state that this incidence is more or less 5–7%, but given the high number of sleeve gastrectomy performed, it can be a serious health problem. Putative mechanism of post-sleeve gastrectomy GERD probably is one of the best study, because we can have increased intraluminal pressure, intragastric pressure, an increased gastroesophageal pressure gradient, section of LES muscle fibers. We still don't know about the residual fundus role, the middle gastric stricture role, preoperative missed assessment of GERD or hiatal hernia, and to extend the preparation of the left crura, pillar, and what about the duodenogastric esophageal reflux, biliary reflux due to reduced size of the antrum. We know that gastric fundus contributes to have the isobaric condition of the stomach, and in this beautiful work provided by Perretta and Mark show that after sleeve gastrectomy we can have also the reduction of the angle of His, so that is one of the competent function that we have of our EGJ structure. Also in 2014 we showed that also in asymptomatic patient after sleeve gastrectomy we can have the increased gastric pressure with a reflux, like a regurgitation that we can see at impedance. We describe it as a bounced bolus back, and in fact we showed that after sleeve gastrectomy there was an increased number of postprandial episodes. We replicated this study in a duocentric experience with Sabine. Also in this, we showed the role of the increased intragastric pressure after sleeve, and also we tried to verify if this was related to the shape of the sleeve, but it was nearly impossible because sleeve shape is really too variable, but you have at least to assess the presence of the middle gastric stenosis that can be one of the cause of GERD after sleeve. Sleeve can impact on the esophageal motor disorder. We still don't know. We have this report. It was a retrospective report from a French group, but there are some bias. There were some patients with a preoperative achalasia that were also submitted to sleeve gastrectomy with an atal hernia repair. So probably the bias is related to the retrospective court. So sleeve gastrectomy was total not efficacy as a treatment for this motility disorder. What about one anastomosis gastric bypass? Usually it resembles the bilirubinemia 2, but it has a totally different mechanism. We showed that there is a reduced intragastric pressure in comparison to the sleeve gastrectomy, probably for the anastomosis that we have between the gastric sleeve and the jejunal part, so with a reduced number of reflux. And we also saw, to compare with bilirot, in which the fundus was residual, and we also in this case checked that the intragastric pressure modified by the intervention was probably one of the main mechanisms for having reflux or to be a protective factors against reflux. And finally, we have this beautiful study from the American group. They firstly described that there is not only the increased intragastric pressure, but this increased intragastric pressure can be related to a unique high-resolution motor pattern that can be an aperistalsis achalasia-like, and authors called post-obesity surgery esophageal dysfunction posed. And they described up to 30% of this motility after both sleeve gastrectomy and Roux-en-Y gastric bypass. So it is a really huge problem. So concluding, we know that obese are a high risk of GERD, even silent, and also motor dysfunction can be present. After surgery, pathophysiological modification are likely to occur, so objective tests should be mandatory. I will not have an answer, but because we have the statement. And there are also my concern that do we need normative values for this patient according to different grades of BMI, and what to do before and after bariatric surgery? What is the correct strategy? Thank you very much.
So that was an incredibly comprehensive run-through. I do think that to mirror what was said about anti-reflux surgery, one person's sleeve gastrectomy, one surgeon's sleeve gastrectomy is not necessarily another surgeon's sleeve gastrectomy. In Basel, I work with Ralph Peterli, and we've just completed a large, it's published in SWORD, of about 70 to 80 people, prospectively comparing bypass with sleeve, and we saw nothing like this rate of dysmotility. We did see increased reflux in post-sleeve, but we rarely saw this massive obstruction, although we did see it, but it was really occasional and normally to do with that post-stenosis. But perhaps the most important thing, because so objective and so concerning, we saw after 7 years, no increase in Barrett esophagus, no measurable increase. And we think this is a massive pre-test bias. These people in this 18% rate, they hadn't got a pre-test result to refer to. So of course, if they had Barrett beforehand, we know they could easily have Barrett afterwards. Just to sort of relativize, because one could really get the idea one shouldn't do any of this at any point. So that with that conservative statement, Roberto.
Yeah, Salvatore, thank you very much for your comprehensive talk. Now, if I have understood well, getting back to your initial statements before surgery, that high-resolution manometry has to be done if there are symptoms, right, only, but also if a patient has reflux symptoms, also reflux testing is your statement. Does your statement say that it is to be done? And if yes, does that statement or another statement say that you should make a different decision whether you have reflux or not? For instance, when you plan to do sleeve gastrectomy, which is the operation, for instance, that in our area is done more frequently.
Thank you, Roberto. I showed the two statements, and I didn't show the vote unless Renato will treat me not really well. I presented two statements. One statement was if we have to do in all patients high resolution manometry, and the other was we have to do